It's not just that government is bad or resistant. It's like it's a challenging thing for government to work across administrative silos.
Whether you're from Canada or from the United States, the reality is that there are thousands and thousands of people who do not have access to quality health care. And until everyone has the same access to health care, we're not really treating health care as a basic human right. In neither Canada or the United States, though we've both signed the Declaration of Human Rights, we don't really respect housing as a basic human right, and particularly we have not really learned to put into practice human rights for the most marginalized people in our community, and I think that should be the larger vision that we're upholding as we continue this summit series and as we continue then to go home and apply what we've learned here in our day-to-day work.
If we can really begin to push on housing policy, I think increasingly this understanding of how the structural interventions like housing do have a positive impact, that we really need that reinvestment of resources back into affordable housing. We need safe, decent, and affordable housing for everyone. And so the more that we can begin to focus on that and really start seeing in the national dialogue, if there was a policy shift, understanding that housing in itself and then some of the other structural interventions is treatment. So it's not just about linkage, but it's about treatment. It is about prevention. And carrying that message into the broader policy conversations, I think is going to be critically important. And I think that helps us with the next step, which is really bringing together systems that don't communicate. We were just in there talking about how treatment's on one side and prevention is on another side, and they don't talk about, well, we're not even talking about housing systems and health systems actually coming together or food and nutrition coming together. And so I think the mantra needs to be housing is treatment and should be seen as critically important. And so if we can begin that over the next 10 years, really pushing that as a policy focus, I think we can make a tremendous strides in ending the HIV/AIDS epidemic.
We have to think about how to work together in a collaborative way more effectively. And it's not easy to do. And the best model is the model I like is called collective impact, right? Which means working very differently. It doesn't just mean collaborating, because anybody can say that, yeah, we collaborate, but it's like, what exactly are you collaborating on? What are you going to bring to the table? But also, what are you going to let go of? Because that's where often things fall apart. It's like, yes, I believe in this change, but to do this, it means you're going to have to stop doing this thing you've been doing for years, and people don't want to do that. So, but you can get there, but it's not easy. But that collective impact where we draw on the resources and knowledge and tactics of different entities and different professions and different stakeholders, then you can come at an issue in a very dynamic way, be nimble, and bring the resources to bear in the right place at the right time.
Another thing that I wanted to mention very quickly too, even though we're really happy that we passed the Affordable Care Act in the United States, that it's finally safe from further intervention from the Supreme Court and other issues, is that even with the Affordable Care Act, there are disparities that are going to persist. And there have been a slew of studies looking at health care availability within the U.S. Military service, where you have purportedly similar health care for all individuals. And what they found is that disparities even exist when you have similar health care for all individuals. So one study found that there was poor retention in care across the medical or military places. You find geographic variation in adoption of some of the more advanced HIV medications across military services. You also find that African Americans are less likely to achieve viral suppression in the military compared with whites, despite the fact that African Americans have just as much access to care as whites. And you'll also find racial differences in virologic suppression. So there's something else that's also taking place that we need to take a look at with the social determinants of health to try and figure out what's happening. It's not just if we provide health care for all that we're magically going to see a lot of these disparities disappear.
So I was at the Vancouver Pride Parade, and I invited this young HIV positive member to come and march with us in the Pride Parade. And there was a little thing of either heat exhaustion or just pure exhaustion from not eating in the morning. And so the paramedic was called over at the end of the Pride Parade. And there was a disclosure that this individual, for the last 4 days, ran out of their HIV meds and wasn't taking them. Now, this speaks to a much broader issue. The broader issue is like in here, and this is what I shared today for the PACHA meeting of looking at social determinants of health, is here's a system they have free, completely 100% free access to care. And the way in which that the medical system is set up in Canada, they don't even have to set up a meeting or an appointment with their doctor. They can call the pharmacist calls the doctor, they get a script, and then the pharmacist hands over the pills. And we can do all of those things. We can have the most, here in the States, we can have the development of the best Ryan White program. We can have the universal health care like ACA. But if we don't have the mental health and the behavior health supports there to say you are valuable, and the person believes and hears that and they say it themselves, there's nothing we can do. I just don't understand how someone who has that level of care and that access to care is gone 4 days without meds. It's dumbfounding to me.
The Office of AIDS Research came out and they listed the priorities for AIDS-designated funds. Now, this doesn't mean that, NIH is not funding AIDS research anymore, but what they listed as their high priorities in this research were the things on the left. So they want a focus on reducing HIV incidence, primarily through the development of vaccines, the development of the next generation of HIV therapies, a cure, research on a cure, and a focus on comorbidities, HIV-related comorbidities and co-infections. What they listed as the lowest priorities for AIDS-designated funds, and so these are, National Institutes of Health funds for research, are a lot of what we've been talking about this morning. Specifically, studies of behaviors. They give the example, and this is directly from the report, sexual activities, drug use activities, or social conditions that have multiple negative outcomes where HIV/AIDS is only one of many outcomes being studied without a focus on how HIV/AIDS is unique in that context. And so sort of what we see is sort of diametrically opposed our understanding about social drivers and what we're talking about this morning and where the funding is going as we turn our attention in terms of federal funds for AIDS research more on the biomedical.
So moving research evidence into action, it's incredible how much research we generate. And I think what we're doing is trying to take a conscious look at that evidence from single studies to bodies of work to systematic reviews in very rigorous ways to understand, what is the evidence telling us and how we can act on it. And so we spend a lot of time we have teams at the OHTN and others that we're involved with spend considerable amount of time really making sure that we're not duplicating efforts or how we can learn from studies that are happening in different places, in different contexts, and take that work and then apply it or look how we can adapt and apply it in our local communities, in our regions. And so there's a lot of work sort of really wanting to synthesize that, but then apply it. And I think our approach to interventions is to make sure that we're really have the latest evidence, and then the next piece is to then think about a lot of the work that we're doing is working with people and priority populations in their communities and their social contexts. And so our next step is to think about not just what the findings told us, but then how we can then build those into approaches, interventions, and programs to really help people to look at how we can change the negative things that happen to people through this intervention work.